A 34-year-old man comes to the physician for genetic counseling because of concern about his family history of cancer. A pedigree is shown. Colonoscopy is performed, showing a small number of polyps in his ascending colon. Vital signs are normal, and physical examination is unremarkable. Which of the following genetic principles best explains this patient's increased risk for developing a malignancy similar to those in his family? Choice A, variable expressivity. Choice B, anticipation. Choice C, pleiotropy. Choice D, penetrance. Choice E, homozygosity. Choice F, heteroplasmy. Or choice G, X-linked inheritance. And of course I have this pedigree up here. Ignore the fact that the squares and the circles might be of different sizes and some of the lines are of different thicknesses. That's just a result of the crappy program I used to draw it. I have an arrow pointing to the second square on the third row. That's our patient. So I'll just wait another 5 seconds and I'll start answering the question. Alright, so in this question, I actually gave you enough information in the vignette to answer the question without even looking at the pedigree. But I'm going to go ahead and talk about the pedigree anyway, just because that's part of what I want to teach in this question. So obviously when you get one of these charts and you feel like you need to interpret it, there's an algorithm that people use. First, you check if there is a diseased mom passing it to all her kids. We don't have that here, but if we did, we would conclude that it's a mitochondrial disease. And we don't really need to do anything else beyond that unless something was suggesting to us otherwise. So after we rule out mitochondrial, we check every single generation and see if it ever skips a generation. If it never skips a generation, then we have a dominant mode of inheritance. If it does skip a generation, then it's recessive. And then finally after that, we check if there's male-to-male transfer. If it does have male-to-male transfer, then we conclude that it is an autosomal disease. And if it does not have male-to-male transfer, then we suggest that it is probably an X-linked disease. And that is, of course, because an X-linked disease would mean that since it's on the X chromosome, a dad can't pass it to his sons, because if he's sick and the disease is on his X chromosome, he wouldn't pass it to his sons because he's donating the Y chromosome for those children. Anyway, here we can see that his grandpa had the disease. His dad had the disease, some of his uncles have the disease, and one of his uncles passed it down to his kids as well. It's in every generation. It does have male-to-male transfer, so we conclude that this is autosomal dominant. But like I said, just the vignette where they tell you they did a colonoscopy and they saw a small number of polyps in the ascending colon, this is pretty buzzy for Lynch syndrome, hereditary non-polyposis colorectal cancer. So like we said, it's autosomal dominant, which generally means you'll pass it to about half your kids if you have children with someone who does not have a trait at all. However, we know that in familial cancer syndromes like this one, or BRCA, or APC, whatever, not every person gets cancer even though they might have inherited the gene. So to explain that, we call that incomplete penetrance. So the answer here is choice D, penetrance. Now, just to talk a little bit more about Lynch syndrome, since it's actually pretty important, like I said, if you ever find polyps in this disease, it'll be just a couple polyps, and it'll usually be in the ascending or proximal colon. Even though it's called non-polyposis colorectal cancer, yes, you can still find polyps in it. The main reason they like harping on this is because you use it to contrast FAP, FAP, familial adenomatous polyposis, which is due to a mutation in the APC gene. In that condition, you'll have a crazy number of polyps, okay? Like it's in the distal colon, it's in the descending colon. And usually you'll do a colonoscopy and they're just everywhere. And most patients with FAP will end up getting total colectomy pretty early on in life because it's just very dangerous for developing colorectal cancer. So while we're on the topic, there's obviously some other colorectal familial cancers you should be aware of. There's Peutz-Jeghers, also autosomal dominant STK11 gene. That one's really buzzy because you get mucocutaneous hyperpigmentation. Basically, you get like these little black spots on the lips a lot of the time. And when it grows polyps in the GI tract, they will be hamartomatous polyps. And we can sit here and talk about a lot of other familial cancer syndromes, right? There's the multiple endocrine neoplasia syndromes, MEN1, MEN2A, MEN2B. There's von Hippel-Lindau. There's BRCA, Li-Fraumeni, neurofibromatosis, retinoblastoma, tuberous sclerosis. One cheat code, I guess, you can use on the exam is that the majority of these familial cancer syndromes are autosomal dominant. So even though I encourage you to be very familiar with all of those because they all come up on USMLE, if you forget or you're just backed in a corner and you just can't remember, just think that most of these familial cancer syndromes are autosomal dominant. So anyway, let's not get too distracted for the main genetics points we're trying to make here. So let's just look at the other answer choices, okay? Choice A, variable expressivity. This is describing when you have two patients with the same condition having vastly different presentations. So this would be like, for example, neurofibromatosis. For example, one person with neurofibromatosis type 1, they might have all the skin findings, but none of the cancers. Whereas another person has just everything. They have the cancers, they have optic glioma, they have neuropathies. Not too complicated. Choice B, anticipation. This is when you have a disease presentation changing in each successive generation, and usually it gets more and more severe. So classically, we would think of Huntington's. Patients will present with the symptoms earlier in life, and it'll just get earlier and earlier as the generations go along. Usually happens with the trinucleotide repeat conditions, so like myotonic dystrophy, Fragile X. Anyway, choice C, pleiotropy. This means when you have a single mutation in a gene and it causes several phenotypic traits. So, for example, Marfan syndrome can affect height, it can affect vision, it can affect the heart, but that's all from the mutation of just one gene. Now, while yes, you can argue that pleiotropy technically does apply to Lynch syndrome since it affects patients in a way where they could have various different cancers, that's not what the question was asking. The question was asking, why does he have increased risk of malignancy, or how do you describe him having increased risk of malignancy? That has nothing to do with pleiotropy. That's more just the fact that some of the people with Lynch syndrome will have cancer and some will not. That's more related to penetrance. Choice E, homozygosity. I mean, this is an autosomal dominant disease, as we said. So that would be a heterozygous inheritance, right? You would only need one gene from a parent to have the condition. Autosomal dominant conditions are very rarely homozygous. Usually, if you get homozygous genes for autosomal dominant mutations, that's actually fatal in a lot of conditions. There is, in fact, an older MBME question where they force you to pick homozygous on autosomal dominant condition. I don't want to spoil which condition it is just because I don't want to affect your score too much when you go and test it. But that's one of those weird cases where none of the other answer choices really make sense. Although in my opinion, that MBME question just isn't a very good question. Maybe that's why it's on an older form, but still notable, I guess. Anyway, this is the wrong answer, right? Choice F, heteroplasmy. Anytime you see the term heteroplasmy, you should think mitochondrial condition. This is a term pretty much only applied to mitochondrial diseases. And this is essentially variable expressivity except for mitochondrial diseases. This results from mitochondrial DNA having both healthy and diseased DNA in various cells. So you end up having a different level of disease expression between people who have a mitochondrial disease. So that's heteroplasmy. Choice G, X-linked inheritance. I mean, we already talked about it. This is an autosomal dominant condition in this case. If this was an X-linked disease, you would not see a male parent passing to a male child. Because again, a dad cannot pass their X chromosome to a son because they're giving the Y chromosome. That's what makes them a son in the first place. Now, just to address real quick, some of you might have looked at this pedigree and got really confused, and you might be like, why do none of his aunts have the condition? Like, why was it only passed to men? This was just me being a jerk and drawing an incredibly unlikely but still valid pedigree where only the men got an autosomal dominant condition. I did this because the question that I based this off of, again, I don't want to spoil it too much, they also draw a pedigree where there's something kind of weird like this going on, where yes, it's still technically a valid pedigree for the type of inheritance it was, but it felt like they were deliberately drawing it to be kind of weird, to be misleading. So I guess your main takeaway on that is like, don't confuse yourself. Like, don't overcomplicate the question. And also know the conditions and read the vignette. Like I said, even if I didn't give you the pedigree in this question, you probably still could have answered it, because penetrance is the only answer choice that makes sense after I've given you enough information to suspect Lynch syndrome. So this video is getting kind of long, so let's just sum it up, okay? With pedigrees, first you check if mom passes it to all her kids for mitochondrial. If that's not true, then you check every generation to see if it's a dominant disease. If it's in every generation, it's dominant. If it skips a generation, then it's recessive. And then you check if there's male-to-male transfer. If there is male-to-male transfer, it's autosomal. If there is not male-to-male transfer, you should start suspecting X-linked disease. And in this case, Lynch syndrome, autosomal dominant. Most familial cancers are autosomal dominant. Lynch syndrome differentiated from familial adenomatous polyposis by the fact that it has fewer polyps and it's in the ascending colon, aka proximal colon, as opposed to descending / distal colon. And of course, it leads to increased colorectal cancer risk, as well as various GI cancers, as well as endometrial cancer. I hope this video was helpful. I'll see you in the next one.